Okay, so with the history a little bit, or actually the history was like GI bleeding.
Just
Good. So this looks
lymphoma.
really similar to a case that I showed.
Lymphoma. Yeah, I would also add lymphoma in there.
Exactly, yeah. So that's like the main thing, right? And it
Yeah.
is like this part looks like a gist, like it's exophytic. It could have like mucosal ulceration with air going into it, but then it is kind of growing like up the mesentery up here.
Mm-hmm.
Okay. And I'll show you the coronal. Oh, actually, hold on, sorry. This is the current coronal, or like the case I'm showing here. So you see it's like growing up the mesentery. So lymphoma is definitely up there. And then this was just like 3 months prior. So it was like grew in 3 months. So I was like pretty convinced it was going to be some aggressive lymphoma. But the
Mm-hmm.
history is actually the patient has melanoma. And then I
Ooh,
was like, well, like, still could it be like some kind of lymphoma that grew while like they were on immunotherapy or something like
Uh-huh.
that? But they went to resection and it was melanoma.
isn't it melanoma like the most common, one of the most common malignant small bowel
Yes. And I'm going to show
malignancy?
you this case from Radiopedia that looks pretty similar to mine,
Mm-hmm.
Mm,
right? Where it's
yeah.
kind of almost got that aneurysmal bowel look like lymphoma. And then this was exactly what you were just saying, Nelly. So Mets, the GI tract is rare, but melanoma is the most common primary and small bowel is the most common location. And then there's several different patterns. So you can get little nodules that cause intussusception, ulcerating nodules, serosal deposits, so coming from the mesentery onto the bowel, and then larger infiltrating masses like this one with dilated luminal segments. So just a good, example of like something mimicking a lymphoma, but if they have a history of melanoma, that can definitely still be a melanoma pattern.
Yeah, melanoma and breast will be common ones which will go to bowel. And one thing which was like striking in the coronal image you showed, there was tumor in vein.
Let me see.
Oh, yeah, yeah. There. Is it
Yeah.
tumor or is it bland? Can you tell? Oh, yeah, it
There's
looks
some
kind of,
bland
yeah, it's
thrombus there,
extending.
but there's probably some tumor thrombus starting there.
Yeah,
Yeah.
like
Great.
contiguous
Great
almost.
pickup.
And plus it's very heterogeneous. So like lymphoma, if it is lymphoma, then aggressive one.
Yeah, exactly. So when you say tumor in vein, is that something common in melanoma?
No, I thought it was not seen. I mean, I can't say not seen, but we don't see tumor in vein in lymphoma. Have we seen? I'm just thinking aloud.
Yeah, that's a good point. Um, I don't think I've seen that. I've seen it with even neuroendocrine tumors,
Mm-hmm.
like and obviously the typical ones like HCC, RCC, ACC. Yeah, okay. I have a companion kind of
Sure.
case. Okay. This patient also has melanoma. I'll just point out there was like some uptake here in the
Mm-hmm.
liver, here next to the like or around the region of the SMV, and then we have some mesenteric nodules,
Sorry, what was the primary again?
melanoma.
Okay. Oh,
And
sorry.
then this is an FDG PET. So they were pointing out, like they thought, these mesenteric nodules were all kind of suspicious. All of this stuff here was all really suspicious. And then they didn't really know, what to make of the liver because on the non-contrast CT for the PET CT, they couldn't see anything. So we did an MR, and I'm just gonna cut to the exciting part.
Oh, tumor in vein.
Yeah. That's why I was just asking you about the melanoma tumor in vein. So so there was actually tumor in vein in the right portal vein, and then also in the SMV. And then all of those things that were avid on PET were like super bright. So this is the T1 bright melanocytic melanoma example. Beautiful example of how bright it can be and localizing it to like the veins on the MRI.
So asked Copilot, if we see tumor in vein with melanoma metastasis,
Yeah.
and it says direct venous invasion by metastatic melanoma to the small bowel is uncommon. Most cases are intramural or mural growth rather than extension into mesenteric veins. when vascular invasion do occur, it's more frequently documented in hepatic and portal venous system rather
wow.
than the mesenteric veins. So imaging pitfall exists because tumor thrombus can mimic bland thrombus.
Yeah. And actually this one, because it's so bright, it's hard to see it on the other phases, right? Like it just blends in. Here it's
Yeah.
a little bit, yeah, more heterogeneous and stuff. But anyway, yeah, it was just a cool example.
Wait, for me, right?
Oh, not for
Yeah. So this is a patient with, or actually, what do you guys think?
endometriosis.
Yeah, exactly. Good,
With a
good, good,
huge scar endometrioma.
good, good. Exactly. So let me pull up the T1 and
Wow. Huge.
that's the T1. And then I want to bring up also diffusion. Okay. Yes, so pretty significant abdominal wall, deep scar endometriosis, deep infiltrating endometriosis.
I have a question.
And
What are you trying to show us with the diffusion?
well, you tell me what you see. Yeah. Or what do you think? What would you say in your report?
Some amount of diffusion restriction. Again, like blood products, hematoma can show it. Or are you trying to say that how do we differentiate it from endometrioid carcinoma in endometrioma?
If you were seeing this, what would you say in your report?
I think I would say large scar endometrioma. I do see that solid part along the posterior aspect,
Uh-huh.
but you can get fibrotic scarring in scar endometriosis, and you
Good.
can get a
Yeah.
lot of enhancement without necessarily having malignancy.
Mm-hmm. So this was resected, and there was endometriosis and endometriomas. And in addition, there was mesothelioma, epithelioid type. And I'm sharing this because I learned that you can get mesotheliomas from endometriosis. So I searched this on Google, and the Google AI shared with me what I'm going to share with you now. There are specific groups of mesotheliomas in young adults. 48. This is a young woman with genetic alterations in FUS fusion with ATF, and these are associated with endometriosis. There's no asbestosis exposure, and they have a kind of specific histologic pattern that is epithelioid in morphology. And it's rare, but it is seen with endometriosis. I didn't know that. I've never seen a case.
I
So
haven't either. Like I always think about endometrioid or clear cell.
correct. Yes, yes. Same here. But that so now we know.
And Nelly,
Yeah.
did you prospectively or retrospectively call
I've,
like there was malignant degeneration here?
no, no. I described it just as benign, uh, and described the specific things that the surgeons were looking for, kind of surgeons.
Yeah, that's a rare case. Does your Google AI, can it tell you like what percentage, like when you do have malignant degeneration and endometrioma or scar endometriosis, like what are the percentages of these different ones?
The mesotheliomas in
Yeah,
endometriosis.
and like all the different malignancies. Do you have like some?
Oh, I don't know it off but I would say that this is so rare that it's case
Super rare.
reportable.
Yeah, cool.
So I just Googled your question, Aarti, and it says malignancy is incidence of up to 1%. And so it's rare. And then I mean, it's already rare. So to subtype the different variants, I'm like, clear cell, I think are probably a lot more common, and mesotheliomas are just ultra rare. And
Yeah.
again, case reportable.
We had 2 cases here of malignant degeneration in eschar endometrioma, and they were like huge, and I think that they both ended up being clear cell. Cool.
So this is 2 years before the patient presented to us. And what do you see? I can pick on Aarti, can I?
There's
Oh, I just saw some stuff. Okay.
the duodenum. Oh, go ahead.
No, you can take it. I think, yeah, the duodenum does look like thickened.
Yeah, there's like an ulceration in the fourth portion of the duodenum and thickening.
I think maybe we can ignore that. That's
Oh,
from
okay.
2 years
Just
prior.
kidding.
Sorry. And the patient presents with acute abdomen today.
I was gonna say the gallbladder looked a little weird.
Yeah.
Yeah, now it's got cholecystitis.
Yeah.
And
She's had a
what
bunch
else?
of surgery. Did the patient have liver transplant?
Wait,
Yes.
the common bile
Wait,
duct
but what? I'm
enhancing.
sorry. Liver transplant. Wait, the patient has a gallbladder, so cannot have liver transplant. But there's a lot of staples.
What if I told you the patient's GB was removed?
Oh, is this a duplicated gallbladder?
Duplicated gallbladder?
That's a great thought. So we thought maybe it is remnant. Like at times they can't remove the entire gallbladder. So we were thinking in terms of if it was remnant gallbladder which just got enlarged and again has stones and acute coli. But
What about a stump? Could it be a weird? Can you show me the coronal? I love the coronals.
I can show coronals.
Okay.
It's definitely
Looks like
like
a gallbladder.
Gallbladder looking. It doesn't look like a right posterior duct running.
Yeah, and I see it follow
Cystic
going into the cystic duct, I think. There, yeah, I can follow the cystic duct.
Yeah, I think somebody pointed out about the surgery. So basically the patient has had hepatic transplant.
Was it like I mean, the whole liver's there, so it's not like a part liver.
So the patient wouldn't have gallbladder from transplant.
So that's like they left the gallbladder, the original gallbladder.
They removed the gallbladder.
Did they forget to take it out?
No, they removed it.
Oh, okay.
This
So
is a duplicated gallbladder.
no. So basically, this is a mucocele of cystic stump.
Oh,
Then I'll talk about the theory in a bit. This patient was a poor surgical candidate, so they tried draining it from inside, transpapillary drainage. It does look like a gallbladder. And let me show you what we found online.
You were basically right. Like it was a cystic duct remnant / like subtotal cholecystectomy. That then
It looks like a gallbladder.
Yeah, that ballooned out because of like mucocele. Oh.
So there's a case report from 2017, and this patient also had a hepatic transplant and presented with acute abdomen, and we see something looking like gallbladder. When basically it was after transplant, can't be gallbladder. So it was mucocele of the cystic duct remnant. And I found 8 cases from 1990. Why does this not open?
Did they have did they have older images that showed a normal cystic duct? Like, did it develop after the transplant, or was it pre?
After the transplant. And we have 8 cases here and it just shows filling defect from outside or just so one of the mechanisms they talk about is the joining of cystic duct to CVD can be variable. So there's a possibility that that is sutured when they suture the CVD. And because of the end pouch, like the blind ending pouch, it just secretes mucus and accumulates and looks like a gallbladder.
So it's from a stenosis downstream. That's why it's
Yeah,
not able
they
to
just
decompress.
suture it, suture the end of the cystic duct.
That makes sense that why you're calling it a mucocele, because it's like creating some mucus as opposed to being backfilled with bile, like a normal gallbladder or a normal cystic duct. Cool.
And
This makes so
why
much
do they?
sense because I had a case recently where it was a liver transplant patient, but there was a gallbladder. And our theory was like they forgot to take the gallbladder off. But this is like it looked exactly like this. So now I would probably call it a mucocele.
I have a question. So the surgical technique that they use, is that common?
What do you mean surgical technique?
Like when they suture it off, which then
No,
creates.
no, no, no. It can be sutured inadvertently because the joining of CVD to cystic duct can be variable. That's what these guys have said could be one of the mechanisms that inadvertently the
Oh,
cystic duct
okay,
is
got it.
sutured.
So it's an iatrogenic. It's
Yes.
iatrogenic,
Yeah.
basically. This is unexpected and not. Yeah, it's a complication from surgical iatrogenic. Yeah, cause.
Cool. Okay. Tell me if you see anything.
Polysplenia.
Good.
Dorsal agenesis of pancreas.
Excellent. Truncated pancreas here.
I want to see the IVC.
Great. So here's our IVC.
Oh, some azygous, hemiazygous continuation.
Exactly. So there's azygous continuation of the IVC. Anything else you notice about it? So I'll just
Duodenum.
yes, and so actually there's malrotation as well. So the small bowel is all located on the right side, and the colon is all located on the left side. The duodenum does not cross the midline. So these are all congenital anomalies. Some of them are described together. So azygous continuation, polysplenia, and truncated pancreas are often described together, and they can be with and without cardiac anomalies. And I think the intestinal malrotation must be related, although I couldn't really find it that described. But the interesting thing is this patient was having SVT, supraventricular tachycardia, and they went for an electrophysiology procedure. They went through their groin, went up the IVC, and then like couldn't get into their heart. And what we and the indication for the exam was question interrupted IVC. And what we saw was that the IVC was actually severely narrowed here at the level of the renal veins. This is not necessarily like common in azygous continuation. Usually you just see like a big IVC that just continues over into the azygous. But in this particular case, for some reason, it was also like severely narrowed here. So anyway, just to usually azygous continuation of the IVC is incidental. The patients are usually asymptomatic. But there can be issues. And one of the things that even in Radiopedia they talked about was that like if you have to go for a procedure, that can cause some issues. Like say you want to try to get into the heart, but you have to go all the way through this azygous continuation, or in my case, like where it was like severely narrowed, and that makes it much more difficult to do procedures through the IVC. There's not really much symptom from having polysplenia or the truncated pancreas. And then malrotation can be an issue sometimes with children, usually just incidental in adults.
Yeah, azygous is more common than hemiazygous, and like when we talk about IVC interruptions, so we group them in IVC interruption anomalies, azygous and hemiazygous, because the infrahepatic IVC does not go into liver and to the right atrium. So liver has its own IVC, and which
Exactly, right
drains.
here.
Yeah,
Yep. This
which
short little
drains.
thing, which
Yeah,
actually makes me think like if they needed a transplant, this would also be really difficult, right? Because you don't have
yeah.
like normal big IVC.
Mm-hmm.
Yeah. Tell us more about hemiazygous. Like, how can I tell that versus azygous?
I'm showing that as a companion case next.
Oh, great. Okay, hold on.
So one thing that I always, like, as a med student, I had difficulty remembering which is on the right and which is on the left. So HE, the second letter is E, and left LE, second letter is E. So left is hemiazygous and the other one is the other one, which means azygous is on the right side. So this patient has hemiazygous continuation of IVC, and let's see that. So we have this big, that's the descending aorta, and we have this big vein behind, posterior to the aorta. So that is hemiazygous vein. And then inferiorly, that is going to continue as IVC. So that big vein, it crosses over and it becomes the IVC. And IVC also here is left-sided.
Nice. So left side is hemiazygous and right side is azygous.
Azygous.
Nice.
You want me to?
Shall I go? So this is a patient with history of a esophageal cancer here, and I can show you kind of what that looks like. Then there's a stent that is malpositioned. And then in addition to that, there's this mass in the right kidney, a heterogeneous kind of cystic mass. And the mass then underwent ultrasound for biopsy. And so they did a contrast enhanced ultrasound that you see here, and it was non-enhancing. So there was not really an enhancing area to kind of do much with, right, for tissue diagnosis. So it was deferred or not done. And then the patient had follow-up, and the follow-up was with MR, and this is what the imaging looks like. And the T1 signal is not, it's ISO. Let me see if I can pull them up side by side so we can see them all together. And
What's all that artifact on it?
yeah, I see what you're saying, like in the anterior. Maybe, you know what? I think there was, it looks like embolization material, or I saw something that was kind of reddense. Where'd it go? I'm sorry, it's not. I'm sorry. It's like, there's like sutures in the, it looks like sutures in the duodenum anteriorly,
Oh,
or
yeah.
like the hemoclips.
Yeah, exactly. They create so much artifact.
Yeah, unfortunate. But I think we were still able to characterize it despite that susceptibility artifact, or at least parts of it. So probably posteriorly is where we see here. Give me give you the T2 there. So it's at least the portions that we can see. There's no enhancement, and the T2 is heterogeneous. It doesn't look good to me, and but the T1 is not. Like there's not really clear evidence of hemorrhage. There's maybe a little bit of focus posteriorly, and there's no enhancement on post-contrast sequences. But it did increase in size compared to the prior studies. So what are your thoughts? And diffusion, I don't think diffusion was helpful, but I'm going to show it anyways. It's just a lot of susceptibility artifact. So not helpful there.
So this reminds me of like the whole, is this a gnarly hemorrhagic cyst or is it like a very necrotic hemorrhagic papillary RCC? And then of course you have that huge esophageal cancer, but I have not really seen like a solitary met to the kidney. So I'm still thinking this is like more of a separate process.
So they went and did a ultrasound guided biopsy, and it showed, and I'm reading to you directly from the path report, rare fragments of tumor not otherwise specific for primary site of origin. So the patient also has known history of papillary bladder cancer and had been treated with TURBT. And then, as you saw, the locally advanced esophageal
I have some
cancer.
thoughts on this.
Yeah.
Is it something weird, Entopol Goldman lesion?
What's
Like
that?
something like subcapsular, some hemorrhage in the kidney looks like mass, but it is not mass.
She said the path was tumor of unspecified origin.
Oh, sorry. Okay.
Sorry, what did you say? I want.
Entopol Goldman lesion.
How do you spell that?
Antopol space Goldman.
Oh, there it is. Oh, let me just look at the pictures.
Radial, yeah.
These things, let me see. What is that?
Yeah. Yeah, the first one that you opened. Yeah.
This one?
Yeah, it looks like hemorrhage.
Basically, you're saying like it's kind of like a pseudo lesion that is a subcapsular hematoma?
Yes.
Mm.
Interesting.
Well, now we know a new term. But I guess in this case, this was a tumor. The reason I brought up like that differential that I just said is we've had a few cases recently of this exact kind of appearance where it's growing but we can't like maybe there's some enhancement, maybe there's not. And like really it could be a hemorrhagic cyst or it could be a really like these hemorrhagic papillary RCCs can get really, really necrotic and have almost no enhancement to them. So you have to look really, really carefully to see like, do we see any enhancement or, other things? But I still think that can be hard to tell.
Yes.
No,
Yeah.
that's all I
And that
know.
was one of my differential was this is like a cystic malignancy that just, yeah.
Yeah. And
Anyways, the pathology was kind of anticlimactic because they couldn't really subtype the specific primary, but at least
mm,
we know it was malignant.
mm. I still favor it's a primary renal, even though you said like papillary bladder with TURBT. If they were
Mhm.
able to treat that with TURBT, that sounds more like a T1 or like a low grade bladder.
Yeah, patient, yeah, had low grade bladder. I don't think it's from bladder.
Yeah. And then the esophagus thing was massive. So I guess it could be a Met. Always possible. Okay. Focus on the gallbladder.
There's a mass in the anterior wall
Okay, yeah. So this is a
and a
nice
stone.
example of like dark stone versus evil gray mass. Tell me more about the mass.
ICPN.
Polypoid. Yep.
It's polypoid, yeah, and possibly an ICPN. And actually, let me show you the prior. So look at the wall now. I felt like maybe it was
Yeah, it's
growing
gray.
into the wall. Okay. And
Yeah.
then this was the prior where it looked a little bit more kind of like intraluminal. And so anyway, I basically said
Do
I
you have
thought
the
it was
diffusion?
yeah, I do. I thought it was ICPN, but possibly with wall invasion here. And let me get the diffusion. Where is it?
How, can what about like carcinoma within that?
Yeah. That's what I mean, but with invasive
Oh,
carcinoma.
features, yeah.
Yeah. When it has invasion, it's invasive adenocarcinoma.
Oh,
But
I see, I
it's
see.
reportedly about 50%. And I don't know why there's no diffusion here. But anyway, it ended up coming out, and the final path was ICPN with no invasive cancer.
Huh. Interesting.
So the two things that take home points. One, we can bring up ICPN and like especially when we see like a polypoid frondy thing. So for those out there, it's intracholecystic papillary neoplasm. It's sort of the IPMN of the gallbladder. Unlike IPMNs of the pancreas, they don't necessarily secrete mucin, but they have more of this polypoid thing. And they don't necessarily have invasive cancer. So even though it's an enhancing suspicious mass, it's much, much better prognosis in this situation. Here it is, enhancing, even on the subtractions, than a de novo gallbladder adenocarcinoma. And this one, even though I kind of brought up like maybe it's invading there, it was not. So great for the patient. One thing that, if you bring up ICPN, they could do a frozen section. They'll be more careful. They're not going to just do like a laparoscopic cholecystectomy, but they might not do like a full like oncologic, radical cholecystectomy where they remove part of the liver. If the like tumor doesn't seem to be touching the liver or invading the liver or yeah. So that is one aspect of like bringing up ICPN. Even though this is still a surgical lesion, it can change management as far as like how they're going to approach it surgically. Yeah. So T2 weighted
Ooh,
imaging of the liver. So that was the T2. This is I'll tell you, it didn't have any fat in it. T1 pre, there's some hemorrhage in it. Arterial phase. Delayed. So there's a bunch of enhancement. This is the subtraction. You can see that there's like these big globules of enhancement. And this was a youngish female.
Angiosarc,
Good thought. It was not. Youngish female, we can always think about an adenoma, which could have hemorrhage in it. That it was not that. This is actually an entity that I showed previously at this conference. So
epithelioid,
no,
no,
epithelium, angioendothelioma. Those are usually like multiple
multiple type.
hemangioma, like targetoid lesions, usually subcapsular. This was like a large T2 bright mass with this whorled appearance. When I showed it at this conference previously, I talked about how it's actually one of the most common tumors in children. This was an undifferentiated embryonal sarcoma of the liver. And it actually has this very, very classic appearance. So we were able to, in this case, call this prospectively, and that's what it came back as.
wow, great job.
No, but only because they learned from our prior case that we showed here. So anyway, they did a right hepatectomy and were able to remove it. That's the other thing that's really important here is whenever you have a liver mass, the surgeon's goal is to leave a future liver remnant. So in this case, the left lobe would be the future liver remnant. And so the important things you want to describe are whether or not that future liver remnant is touching, the left portal vein and the left hepatic artery, if they are touching the tumor. If they're not touching the tumor, then they could possibly still, even though this is massive, they can still do a right hepatectomy. So in this case, the left portal vein, the left hepatic artery were all free from the tumor. The left hepatic vein was also free. So they were able to resect it with a right hepatectomy.
Wow.
Yeah. But those are definitely things you want to describe, like not just like all the right-sided vessels that are touching it, because that side's already going to be taken out. But really, like it is the left side free. And if it was just even more central here, then the left side like often gets caught in the crossfire and might not be resectable. So. And I'll post the link to the companion case when I post it on YouTube.
So this is something I did at SABI. This was my workshop at SABI. And I have a couple of cool cases, I think in total 8 cases. So we'll quickly go over them. And no financial disclosures. A big shout out to my team, and we have it every Tuesday, 2 p.m. So we have Aarti from Emory, she needs no introduction, and we have Nelly from Mayo, Arizona, and a couple of other amazing folks here. And these are my acknowledgements. So my first case is the elderly male, and some piece of history is withheld here. He had this lesion in the scrotum, and palpably it was hard. When ultrasound was done, it looks more cystic, and there is some echogenicity, curvilinear echogenicity. Additionally, the epididymis had some hypoechoic nodules. An MR is done. And we see that we have T2 hyperintense lesion, T2 hypointense rim. That rim did not enhance. I have not shown you pre-contrast or subtraction images, and there was subtle T1 hyperintensity. So if I were to show you only MR, we were thinking in terms of maybe hematoma. But since we had ultrasound and this was hyperechoic, so we were thinking more in terms of some calcification. So soft calcific. Sorry.
Or echinococcus or TB?
You are on the right track. So calcium can be, soft calcium can be hyper on T1. And as Aarti rightly pointed out, TB, so this was actually the patient had bladder cancer and the patient was given intravesical BCG therapy, and this was BCG granuloma or BCG abscesses. So that big thing was BCG abscess, and we saw BCG granuloma in the rest of the epididymis. And there are,
So it refluxed. Wait, is it hematogenous or did it reflux up the seminal vesicles and then drop down into the?
That's a great question. So basically, each time we talk about epididymitis or epididymo-orchitis, almost always it is reflux, retrograde. So be it acute bacterial one, be it tuberculous, it's almost always reflux. So when we say if it is TB in the scrotum, so which means we have to look for TB elsewhere in the GU tract. It could be kidney, it could be bladder, and from there it is refluxing. It can come directly hematogenous also, but like bacterial, TB hematogenous is pretty rare. Does that answer?
They have granulomatous prostatitis?
I was going to say
Also?
this could also go to the prostate, right?
Not this patient. I'm not showing that case, but we have cases in which BCG has caused granulomatous prostatitis.
Nice.
So there are at least 6 patterns in which epididymal tuberculosis or epididymal BCG can present. So our case was something like this and a combination of this. So we have a companion case. So that's the case from my residency. And this is the scan which I did. We used to do our own ultrasounds. So we see the epididymis is markedly enlarged and very, very nodular. There's hardly any vascularity. And it is reminiscent of this pattern. So this was tuberculosis and the entire epididymis was involved and it was heterogeneously hypoechoic and nodular.
Is there a reason it affects the epididymis much more than the testis?
The same reason, like, it has to come first to epididymis, like even in regular bacterial epididymitis as well.
Good point.
So just as a companion, if there
Would
is
imaging be like, I mean, is it predictive of necessarily TB? Like, are there any?
No, not really. But yeah,
Right.
there are certain patterns, like as radiologists, we always talk about patterns. Ultimately, the diagnosis, in fact, like when I made this presentation, I spoke to Dr. Dogra, again, a great GU expert, and I asked him, how do you differentiate testicular sarcoid versus testicular TB? Because do you do do you do FNA? Because literature does describe this. And when I was a resident, we used to give inguinal block, and we have done a couple of FNAs of testicular lesions. So he said mostly that's not required because the patient usually has something like extra GU, and corroborative evidence tells it is TB, it is treated, and if it resolves, then it is TB. So FNAC is not required, and like sacrificing testes is also not required as much. Does that answer
the clinical picture?
Yeah. I mean, there are a couple of patterns. Like as radiologists, we always keep talking about patterns. So yeah, if I see something like this, because I haven't seen a bacterial epididymitis, which is this dark and nodular. I'm showing in the next case, in fact, as a companion, I'm showing bacterial epididymitis. But yeah.
I have a question.
Yeah.
Do they have other like extra scrotal manifestations?
Yes, TB, pulmonary is the commonest.
So this patient had it. So I guess I'm saying
Pulmonary, yes.
it's like that. What that person
Yes.
was saying, you're going to have other. It's going to be a compilation of everything, not just the structural
Yes,
findings,
yes,
to clue you in on more of a systemic process rather than a
correct.
local process.
Multi-system, yes. So just as a comparison, I wanted to show acute bacterial epididymitis. It is acute, so it will be painful, presenting acutely, and there will be vascularity. Here, there is not much vascularity in the center because it is becoming more phlegmonous and abscess-like. This is extreme form of bacterial epididymitis. It is hypo, but not supremely hypo, and it is still regular. It's not nodular, and it had like a lot of vascularity. So that those things will not be present in something which is chronic, like TB. Good until here?
Yeah.
Okay. Next case, we see this large cystic, large isoattenuating mass in the kidney, and there are like multiple hypoattenuating foci within. So if I were to tell you what are your differentials, so we will think in terms of MEST tumor, most likely, but because it's the top for atypical GU infection. So this is a lesion with multiple cysts inside. So these are actually daughter cysts. I have a companion.
I was going to say, am I going to just guess echinococcus for every case?
Yeah, not every case, but yes. Yes.
I was thinking that too. And I'm like, if I were to read this, like, and it's a fresh case, right? And the patient doesn't have history of that, I don't know that I would add that in the differential.
Sure.
Yeah, I've never seen it in a kidney, but this is super cool.
So
Are they from like an endemic region?
say it again.
Are they from an endemic region?
Both the patients are from endemic region, yes.
Okay, got it.
Yeah. The BCG case I showed was from United States, but the other cases, most of them are from endemic region. So I wanted to show this because I don't like the term pathognomonic, because nowadays, like with so much imaging and so much more entities coming up, virtually, like, we see some of the other findings being seen in other entities as well. So, I mean, if you were to show me this, yes, this is very much like echinococcus. It even has wall calcification, but this is from radiographics, and this was actually a MEST tumor. In fact, this appearance, if you put elsewhere, particularly in liver, then I'm more convinced that this is echinococcus. But in kidney, I'm almost never sure that this is going to be hydatid. So if there is a take-home point, in kidney, I'll always think in terms of Bosniak, and I'll always think in terms of some complicated cyst rather than echinococcus. And interestingly, like I did show them this entire chart.
With the MEST, is there an effective way to differentiate a MEST from, like a Bosniak 3 or renal mass?
Not necessarily. I mean, as long as we're giving Bosniak 3 or 4, that's what I think the clinician wants, more than specifically telling is it MEST versus just cystic RCC.
MEST, though, is benign. And
So the
Bosniak
way
3,
I think of it is like when I see that kind of lesion, and often it's like in a 40, 50-year-old like female, like around, perimenopausal, that's another classic one. There's now like also MCN has been looped into MEST. So multilocular cystic nephroma is like combined with MEST. So when I see those, I do specifically bring it up. Like if I see it herniating into the renal pelvis, I'll say like, this appears to be possibly an MCN/MEST spectrum lesion, like which, is a benign entity. Or if I see like this solid and cystic pattern, I do bring it up as a MEST because they might just biopsy it, they might just watch it. So I do think it's different than just saying like, oh, this could be a cystic, like try to differentiate it or bring it up if you think it's in the appropriate.
I absolutely agree, because it changes triage management.
Yeah. Still
Significantly.
often they have to either biopsy them, or a lot of them do come out because like sometimes we can't tell. So
Yeah, and I mean, I haven't looked into this, but would biopsy be diagnostic?
I think so. They have like these stromal elements, like it looks very different than an RCC, I think.
Mm.
Let's let Shant continue.
No, those are great points. Sorry, what did you say?
No, continue.
Okay, so I just showed them this spectrum from liver, and we tell the type. So basically, we talk about type 4, 5 is watch and wait. Type 1 and 3A, we can do percutaneous procedure along with albendazole. Type 2 and 3B has to come surgically out. But whatever pattern is present in kidney, this treatment does not apply. This applies to liver. Kidney, whichever pattern, it has to come out, like the hydatid.
And so in this spectrum, the 4 and 5 are kind of like the more calcified, like burnt out ones that are not as active anymore. So you can just watch them.
Yes.
Okay, got it.
And why is the surgical or treatment approach different for renal? Why is it always surgical for renal?
Yeah, I don't know if they gave a reason, but like we have percutaneous therapies also, but I don't think percutaneous will be as easily applicable in case of kidney, like because with liver, at times we have a lot of liver parenchyma around it to support our needle and whatever. But with kidney, I don't think that will be a possibility, but that's just in my head. They whatever articles I read did not ascribe a reason why should not they do other things.
It also seems like it's so rare that like maybe case by case.
Yeah.
Kidney.
Yeah, liver is definitely the commonest and kidney is not as commonly seen. Maybe that is the reason.
Okay, next.
So this is a 26-year-old male, and this is a very classic appearance of a pathology. Any thoughts? So this is the left kidney. Basically, this is the right kidney, which looks apparently okay. It takes contrast. It's a but the left kidney does not. So there is a typical pattern of calcification in the left kidney, and this is known as lobar pattern of calcification, meaning the papilla and the surrounding cortex forms one lobe of kidney. So this lobar pattern of calcification is pretty classic for tuberculosis. Additionally, there are medially placed lymph nodes which are peripherally calcified, and there is some amount of psoas cold abscess. So pretty classic for TB. Companion, this is also known as putty kidney. So two different companion cases. So kidney is all calcified, and we still see that lobar pattern of calcification. So that's classic for TB. Renal TB can come in two different forms. One is parenchymal that we just saw, and it could be pelvic calyceal. So here we see papillary necrosis. We also see stenosis of one of the calyces. We see stenosis at the pelviuretral junction. And this case also had uretral involvement. And this looks more like PSC, but this is of the ureter. And this is not PSC in that strict sense. This is just sawtooth appearance because of tuberculosis of the ureter.
I've only seen these in books.
Mm-hmm.
I
I don't have all
the
the
same thing. I was like, I never see this, but
Never.
we studied it for board, so I know
Yes.
all these names and stuff. Yeah.
Moving on, we see this elderly female with pelvic fullness. CT, we just see a isoadentic mass to the muscle. Don't know what's going on. Let's do MR. And that's the cervix. That's the claw sign here. And we see again a hydatid.
Echinococcus.
Yeah. So it is one of those intermediate stages because it has all these membranes which have collapsed and a few daughter cysts.
But the ovaries were normal.
Ovaries were normal. Yeah, it's separate from the ovaries. Yeah, that's a great question. Although we have seen echinococcus of the ovaries as well. So again, claw sign, endometrium here. And I just saw very few case reports, and all those case reports, including our case, the localization was more subserosal. I presume it's because of the thick muscle which is inhibiting the growth, but that's just my thoughts. So another case, again, from my residency days, and this is the patient where we gave inguinal block and we FNA'd one of these lesions. So when we see miliary pattern in TB, it could be anything. Sorry, when we see miliary pattern in testes, it could be anything. It could be sarcoid, it could be multifocal seminoma, It could be even a lymphoma in an elderly. But thankfully, the patient also had epididymal involvement, which was pointing towards TB, and the patient was on steroids for an autoimmune condition. So all these pointers, and we did FNA, so we knew it was TB.
It's amazing how your clinical exposure is so different depending on where you trained.
Mm-hmm. And we spoke about this fact that TB, like any other bacterial infection, or even for that matter, viral infection, will come mostly retrograde. Hematogenous is not seen as common. And if it is hematogenous, it is orchitis. Again, like, we talk, when we teach residents, we say isolated orchitis is seen in mumps and sometimes TB, because they can directly go to TB, but mostly it is retrograde. So it has to affect the epididymis first. TB of testes also has at least 4 different patterns. We saw the miliary pattern. I'll show you 1 or 2 more patterns here. So these were the differentials that I discussed. So another case, like I tried doing a good panoramic view, but it wasn't as great. So we see some miliary pattern here and we see some hypoechoic nodule here. So a combination of those 2 patterns. I'm not being able to capture epididymis here, but epididymis was also involved. Another case, so that's the nodule in the epididymis, and those 2 nodular foci are in the testes. Very little vascularity, if at all, because these are chronic, more like granuloma, coagulative necrosis. And this same patient in the contralateral testes, the testes was fine, but had multiple nodules in the epididymis at the base and at the head. So reminiscent of bipolar pattern involving the head and the tail. And I think I have 2 more cases. So we have all seen this appearance, which is SIN salpingitis ischemica nodosa. And this is basically more like a descriptor. It could be seen in any condition, including idiopathic. So with that base, I want to show you another case of a female who was infertile and a known case of tuberculosis. So this case was actually published by my friends. So this patient has both the tubes affected. So to begin with, there is no free peritoneal spill on HSG. Both tubes are affected. The right one shows the SIN pattern and the left one is beaded and normal. So more like rosary bead pattern. So again, pretty classic for tuberculosis.
Wait, and the uterine cavity looks very narrow.
Narrowed as well, yeah.
Okay.
So endometrium is also affected here. So again, SIN pattern and rosary bead pattern. And I think this is the 7th case, and I have 1 more case. Sorry. So we see this twirling movement, and to begin with, it was thought it was pathognomonic for filariasis, but then later they realized they see it in patients who are from non-endemic zones and no travel at all. So we'll talk about this first, and we'll see how we differentiate. So this is adult filarial worms and filarial dance sign. This can be seen virtually anywhere. We have seen it in inguinal nodes, we've seen it in axillary nodes and in breast tissue as well. This is a different case, same worm, and the high power was the same worm. So this is the lymphatic channel. This green thing is the skin or the tegument of the worm. This is the GIT of the worm, and this is the testicle of the worm. So this is the male worm. So how do we...
Wait. Go back. That big round thing is the testicle of the worm.
Yes.
And then what's the black thing? Black arrow on?
This is the GIT, alimentary system.
Wow, it's almost smaller than the testicle.
Yeah.
Wow. That's crazy. Anyway, continue. But do you know, like when you were showing the dance sign, I was thinking about the dancing megasperm.
Yeah, I'm coming to that.
Okay.
Yeah.
It's like, wait a second. Okay.
So if we have endemic history and if we do blood workup, there is high IgE, then we think more in terms of filaria. And this is a different case, and this is the 12. But because they found it in patients who are from non-endemic zone, so this is post-vasectomy or any obstruction to the outlet system, which is the vas difference. So we can see this in 20 to 30% cases of vasectomy. So this is the sperms which are clumped with each other, so they form a megasperm, and under the insonation of ultrasound beam, they just keep dancing or show movement. They will be more seen in the epididymal region because that's where they belong, versus it's difficult to say if it is a dilated lymphatic or not, but these are away from epididymis. So those are the 2 points where we could potentially differentiate between the 2. Does that answer your question?
Nice. Yeah, that's awesome. Love it.
And the last case, this we published in Radiographics recently. So this is a patient, young patient with left scrotal swelling and multiple lesions in the testes, but there is a pattern to the lesions. So it is more hypoechoic in the center, less hypoechoic at the periphery, and does not show much vascularity, at least in the center, maybe a little bit at the periphery. How does it look on MR? So this is T2 weighted MR and multiple lesions, hypoechoic center, iso to slightly hyperintense border, and that hyperintense border here is slightly hyperintense on T1, and that's the only portion which is showing vascularity or post-contrast enhancement. Additionally, the cord is also thickened and shows enhancement. So this is classic syphilitic gamma. So the T2 hypointense center is the coagulative necrosis. Periphery is the region of active inflammation. That's why it was taking more contrast. And the reason I show this case is because NEJM describes it as the modern epidemic of syphilis. And according to CDC, in just 4 years, we have seen 81% increase in the number of syphilitic cases. And the reason is men having sex with men, proportion of them increasing, as well as heterosexual encounters also increasing. And it is interesting, like, one of my favorite sessions at RSNA is on Mondays at the Erie Crown Center at 5:30 on Mondays, and they panel 5 different cases. 2023, they showed an unknown case of meningovascular syphilis, because syphilis definitely is on a rise. So we as radiologists are probably one of the first people who would pick it up or maybe suggest that sometimes. So with that, yes, thank you.
Wow, that was incredible. And I so appreciate you bringing it here too, so it can live on after SABI. And with that, we'll see you next time. Bye.